Hello, this is my final project, and this is what I'll be wearing. This shirt, these black pants, and these black heels. An overview of this project is client intake, static tests, dynamic assessments, mobility assessments, inhibition, lengthening, activation, and integration. My client is a 24-year-old female. She is a retired student athlete. She is a current strength coach. She's physically active 5 times per week, and her overall goals are to increase her squat by 15 pounds and to learn to use proper exercise technique. Client intake forms are necessary before you begin to work with your client. Through these, we learn more about your client, their goals, and their lifestyle, which you can then use to make a more personalized overall training program for them. Static tests allow us to evaluate our client's posture and alignment in a stationary position. While we observe a client, we can look for any postural deviations, which would be caused by muscle imbalances. In order to perform a static test, ask your client to stand in a natural stance with their feet hip-width apart. While they are in this stance, you will observe from 3 angles, anterior, posterior, and lateral, while also looking at the 5 kinetic chain checkpoints. These are the foot and ankle, knee, lumbo, pelvic, hip complex, shoulder and thoracic spine, and head and cervical spine. From the anterior view, my client presented with an elevated left shoulder. She also had an unequal weight distribution, which is shown by her hands in the picture below. The red line is the malalignment, and the green lines are where their alignment should be. From the lateral view, my client presented with cervical forward extension, rounded shoulders, and an anterior pelvic tilt. Posteriorly, my client again presented with an elevated left shoulder. The movement assessments also allow us to evaluate our clients and notice any postural or muscle imbalances throughout the body. There are 3 different types in which we use to assess our clients. First being the transitional movement assessment. During this, we evaluate our client in a stance which their base does not change. So their feet are always in the ground in the same base throughout these assessments. A loaded movement assessment allows us to observe a client while they are under an external load. And the dynamic movement assessment helps us confirm any movement findings in real-world situations, such as walking or running. Throughout these movement assessments, we will observe our clients from 3 angles, anterior, posterior, lateral, while still observing those 5 kinetic chain checkpoints. The movement assessments that I had chosen for my client are overhead squat assessment, single leg squat assessment, overhead press, and the gait assessment. In order to perform an overhead squat assessment, instruct your client to stand feet hip-width shoulder apart and pointed straight and parallel. They are then going to raise their hands over their head, extended straight and aligned with their torso. You're going to ask them to squat in a depth that brings them parallel to the ground, and then they're going to return to their starting position. For each viewpoint, have them repeat 5 repetitions. From having my client perform this assessment, I found that her feet turn out, she still presents with an anterior pelvic tilt, and she has an asymmetric weight shift to the left. The next assessment, single leg squat, helps us assess the dynamic posture, stability, and muscular control. In order to perform this optimally, I have asked my client to stand in a narrow split stance position with her feet pointed straight ahead. My client will then place their hands on her hips, and she will lower to a depth that brings her back knee just above the ground without touching it. Then she will return to the starting position. She will repeat this movement 5 times for each viewpoint. The only misalignment that I noticed with my client is that she still has that asymmetric weight shift to the left. The overhead press assessment allows us to evaluate the strength and stability of the upper extremities. In order to perform this optimally, I have my client stand feet to hip-width shoulder apart and give them a dumbbell that will not challenge them, but not exhausting them. They will have to perform 10 repetitions at a 2-0-2 tempo. In order to perform this, my client will abduct the shoulders and extend her arms until they are straight over her head and the dumbbells pressed together. The only malalignment that I see from her performing this assessment is that her left shoulder is still elevated. The gait assessment, in order to evaluate my client in a real-world setting, she will stand on a treadmill at a 1-degree incline and walk at a comfortable pace as I observe her from all 3 viewpoints. My client showed no abnormal findings or misalignments or deviations. Overall, the total malalignments that I found were the anterior pelvic tilt, elevated left shoulder, asymmetric weight shift, rounded shoulders, cervical forward extension, and feet turnout. The importance of the anterior pelvic tilt is that those who experience it are more likely to suffer from lower back pain. They might have limited range of motion in the trunk, hip, and knee joints, and it can cause a misalignment of the hip joint and spine. The elevated shoulder is also very important to look out for. Those who contain it are at a 43% greater risk of developing shoulder pain. They are also at greater risk of injury. Overall, the overactive and underactive muscles that my client experiences from the anterior pelvic tilt and the elevated left shoulder are latimus dorsi, tensor fascia latae, levator scapulae, pectoralis major, upper trapezius, teres major, anterior deltoid, biceps brachii, rectus femoris, hip adductor complex, spinal extensor complex. And the underactive muscles are lower trapezius, serratus anterior, the rhomboids, gluteus maximus and medius, hamstring, rectus abdominis, external obliques, pectoralis major, pectoralis minor, and the serratus anterior again. The mobility tests chosen for my client are shoulder flexion, shoulder retraction assessment, shoulder internal and external rotation, modified Thomas test, hip adduction external rotation, passive hip internal rotation, and seated hip internal and external rotation. The seated hip internal external rotation and external rotation, my client passed these mobility tests. My client failed the abduction and modified Thomas test. My client also passed the rotation of the shoulder, internal, external, but failed the flexion and retraction of the shoulder mobility joint. In order to correct these overactive and underactive muscles, I have my client perform a series of training programs, first being inhibition. They will do this 5 times per week, 1 set, 1 repetition, 90 seconds per muscle. They will roll up and down the muscle and hold at any tight spots for 30 seconds. A contradiction to this could be a possible recent injuries, and they might feel abnormal sensations. The following muscles that I have my client inhibit are the hip adductor, TFL, biceps femoris, pectoralis major, biceps brachialis, latimus dorsi, and teres major. Lengthening. I will have my client do 5 days per week as well. 1 set, 2 repetitions, 30 seconds for each stretch per muscle, and they'll rest 30 seconds between reps. Any contradiction for her would be an acute injury or muscle strain of the muscle being overstretched. The biceps femoris, hip adductor, and TFL will be lengthened. Each stretch will be held for 30 seconds. The biceps brachii, pectoralis major, latimus dorsi, and teres major will also be stretched. Activation will be used for the underactive muscles. This will happen 3 times per week, 2 sets of 10 repetitions, 1 minute between sets. They will follow a 4-2-1 pattern, and a contradiction could be the muscle that's being strengthened could have a muscular strain or acute injury. My client will be asked to start in a neutral position and perform the exercise for the following muscle groups while maintaining good posture. These are also more examples of activation exercises. The rectus abdominals and external obliques will be held at a plank for 45 seconds with a rest of 30 seconds in between. Integration will happen 3 times per week, 2 sets of 10 repetitions, 1 minute in between. That is it, the end.